Welcome to the deep dive. Imagine trying to get a handle on the health of a whole city.
Or tracking down some, mystery illness.
Exactly.
Uh-huh.
Or figuring out if a new drug actually does what it says it does. How do you even begin?
And then, okay, say you think you found something out. How do you get people in charge to actually, do something about it?
That's exactly what we're getting into today. We're diving into the world of health research, the different kinds of studies researchers use.
Uh-huh. And how all that information, that evidence, shapes the really big public health decisions.
Plus, how technology is just, changing everything.
Right. It's really about sorting through that flood of health news we all see. Our mission here is to, cut through the noise.
Understand what these studies really tell us.
And just as vital, what they can't tell us. Then see how that knowledge gets turned into policy.
And explore the role of tech, powerful, but sometimes kind of tricky.
Yeah. We're drawing on a few sources, a presentation about cross-sectional studies, some background on epidemiology, and randomized controlled trials from Wikipedia.
And an article looking at evidence-based policy and how tech fits into health surveillance.
So think of this as, your guide to the foundations of public health knowledge.
Okay, let's start with the big picture field. Epidemiology.
Right. Epidemiology, at its heart, it's like detective work, but, for populations.
Big-scale detective work.
Yeah. It's the study of who gets sick, when they get sick, where, and the big one, why.
Looking at patterns, right?
Causes, distribution patterns, determinants of health and disease. And the whole point is applying that to prevent illness and, improve health for everybody.
So it's more than just counting sick people. It's about understanding the forces at play.
Exactly. It pulls from all sorts of other fields. You need biology, obviously, to understand diseases.
Statistics to make sense of the numbers.
And social sciences, too, because health happens in a human context, right?
Makes sense. And this idea, looking at populations and their environment, that's not new, is it? I mean, Hippocrates was thinking along these lines ages ago.
He really was. Way back, Hippocrates was one of the first to systematically think about how, where you live and your environment might affect your health.
Didn't he give us some key terms?
He did. Terms like endemic for diseases that just kind of hang around in a place.
An epidemic.
For outbreaks, things that flare up. It was a huge step towards looking at health logically, not just blaming, angry gods or something.
But when you think modern epidemiology, one name really stands out. John Snow.
Oh, absolutely. John Snow. His work in 19th century London is the classic story.
With the cholera outbreaks.
Exactly. Back then, most people believed in the miasma theory.
Bad air causing disease.
Yeah, miasma. Snow wasn't buying it. He went out, mapped where the cholera cases were happening, literally door to door sometimes.
Talking to people, collecting data.
Meticulously. And he traced the big Soho outbreak back to one specific water pump on Broad Street.
The Broad Street pump. Famous now.
It is. And by convincing the authorities to take the handle off that pump, he showed the power of observation, of data. He pinpointed the source, stopped the spread.
And pretty much disproved the miasma theory in the process.
Fundamentally shifted public health thinking.
Yeah.
A real demonstration of using evidence.
Incredible. Okay, so epidemiology needs data. How do researchers actually get that data? Let's talk about study designs, starting with observational studies.
Right. So observational studies are where researchers, observe. They measure things, but they don't intervene or assign people to do anything specific.
They just watch what's happening naturally.
Pretty much. And a very common type, one our sources dig into, is the cross-sectional study.
Ah, the snapshot study, sometimes called prevalence studies too.
Yep, snapshot is a great way to think about it. In a cross-sectional study, you measure both the exposure, like a risk factor, maybe smoking, and the outcome, like lung disease, at the exact same time.
In a specific group of people.
Right, in a defined population at one point in time. It's literally a snapshot of who has what, right then and there.
Like the example they used. Checking cholesterol levels and asking about heart disease all at once.
Perfect example. You go out, survey a bunch of people, measure their cholesterol, ask, do you have diagnosed heart disease? You end up with 4 groups, basically.
Let me guess. High cholesterol and heart disease.
Yep. High cholesterol, no disease.
Disease, but not high cholesterol.
Uh-huh. And neither.
And just by counting those groups, you can see if there's, a connection.
You often use what's called a 2x2 table. It sounds technical, but it's just a grid to organize those counts.
Based on exposure and outcome status.
Exactly. And from that table, you can calculate prevalence. That's the proportion of people in your snapshot who actually have the condition right then.
So how common is it?
Right. And you can compare prevalence too, like what percentage of people with high cholesterol have heart disease versus the percentage of people with normal cholesterol who have it.
Okay, so it's useful for figuring out how widespread something is, and if it seems more common in certain groups within that snapshot. How does that help, say, public health officials?
Oh, it's super useful for planning. If you
Yeah.
know how many people have diabetes or high blood pressure or maybe lack access to healthcare, you can allocate resources better.
Design programs that actually meet the need.
Exactly. The source mentions studies looking at knowledge and practices around family planning in women attending clinics. That's a perfect cross-sectional use case. Understand the current situation to plan interventions.
Makes sense. What are the main advantages, then, of this snapshot method?
Well, compared to studies that track people over years, they're relatively quick.
And cheaper.
Generally, yeah. You can look at multiple exposures and outcomes all in one go. Great for estimating prevalence, like we said.
Useful for planning.
And this is a big one. They are fantastic for generating hypotheses. You see that snapshot association. Maybe people who drink lots of coffee also seem to have lower rates of something.
Doesn't prove coffee causes it.
No, but it gives you an idea. Something worth investigating further with a different type of study.
Okay. And another, plus no one drops out because it's just one point in time.
Right, no loss to follow up. But now for the big catch. The major limitation.
The one you flagged earlier. This is really important, isn't it?
Absolutely critical. A cross-sectional study cannot establish causation. Cannot.
Why not?
Ah.
Because it's just a snapshot.
Exactly. You don't know what came first. Did the high cholesterol lead to the heart disease? Or maybe having heart disease made people change their diet, which then affected their cholesterol.
The chicken and the egg problem.
Precisely. You see two things together, but you have no idea about the timeline. You can show correlation and association, but not that one caused the other.
Okay, that's a huge caveat. Are there other downsides?
A few. Your findings might only apply to the specific group you studied, maybe not generalizable.
Depending on how you pick them.
Right. And if you're looking for a rare disease or a rare exposure, you might need a massive sample size to find enough people.
And potential for bias in who actually agrees to participate.
Yep, selection bias is always a possibility. So, great for a current picture, great for ideas, but not for proving cause and effect. For that, you need other approaches.
Like the other observational study types, case control and cohort.
Exactly. There's still observational, no intervention, but they're designed specifically to get a better handle on that time sequence, that temporal relationship.
Okay, so case control studies.
They look backward.
Right, retrospective.
Yes. You start with the outcome. You find people who have the disease, the cases, and you find a comparable group who don't patrol the controls.
Similar people, just without the disease.
Ideally, yeah. Then you look back in time, you ask them, or look at records about things they might have been exposed to in the past.
Trying to see if the cases were exposed more often than the controls.
That's the goal. You use that 2x2 table again, but this time you calculate something called an odds ratio, or OR.
Odds ratio, what does that tell you?
If the odds ratio is greater than 1, it suggests that the odds of having been exposed were higher for the cases compared to the controls. So the exposure might be linked to the disease.
So you're hunting for past exposures that seem connected to getting sick. These are good for rare diseases, maybe? Yeah, because you start with the sick people.
Exactly. If a disease is rare, waiting for enough people to get it in a forward-looking study could take ages. Case control is faster, often cheaper.
But they have their own issues, like remembering things accurately.
Big time. Recall bias is a major concern. People who are sick might think harder about or remember differently things they were exposed to compared to healthy controls.
Makes sense. Okay, so if case control looks back, cohort studies must look forward.
Right. Perspective. With a cohort study, you start with the exposure. You identify a group of people who have been exposed to something, say, workers in a specific chemical plant.
And a comparison group who haven't been exposed.
Yep. Maybe office workers in the same company or people from the general population. And crucially, none of them have the disease you're interested in at the start.
Okay, so you have exposed and unexposed groups, both healthy and equally. Then what?
Then you follow them forward over time, sometimes years, even decades.
Wow.
And you see who develops the outcome, the disease. Again, you can use a 2x2 table, but here you calculate relative risk, or RRR.
Relative risk. So the risk of getting the disease in the exposed group compared to the risk in the unexposed group.
Exactly. If the relative risk is greater than 1, it means the exposed group was more likely to develop the disease over the follow-up period. It shows an association.
And cohort studies seem stronger for figuring out the time sequence.
Yeah.
Because, the exposure came before the disease developed during follow-up.
Much stronger for establishing temporality than case control or cross-sectional. The exposure is measured first, then you wait for the outcome. And relative risk is generally seen as a more intuitive, direct measure of risk compared to the odds ratio.
But I bet they're a huge undertaking.
Oh, definitely. Much more expensive, take a long time, and you have the problem of people dropping out or moving away over the years.
Lost to follow-up.
Right, which can bias your results if the people who leave are different from those who stay. So these observational studies, cross-sectional, case control, cohort, they're all vital for finding links, exploring risks, generating those crucial hypotheses.
But proving causation, still tricky with just observation.
Very tricky. To get closer to proving cause and effect, especially for treatments or interventions, you often need to move into experimental designs.
Which leads us neatly to randomized controlled trials. RCTs, often called the gold standard, right? Especially in clinical medicine.
That's the term you hear a lot, yes. RCTs are different because they are experimental. The researchers actively do something. They assign participants to different groups.
Typically comparing a new treatment to something else.
Usually, yeah. One group, that's the new thing, the experimental intervention. The other group, the control group, might get the current standard treatment, or maybe a placebo, an inactive lookalike.
And the absolute key part is randomized. Why is randomness so important here?
Randomization is the powerhouse of the RCT. It means participants are assigned to the experimental or control group purely by chance, like flipping a coin.
Not based on doctor's choice or patient preference.
No. And this is incredibly powerful because if done properly with enough people, it tends to balance out all the other factors that could influence the outcome: age, severity of illness, lifestyle, even things we don't know about or can't measure.
So it makes the groups as similar as possible before the treatment starts.
Exactly. It minimizes selection bias and confounding. The idea is that the only systematic difference between the groups becomes the intervention itself. It also makes blinding possible.
Blinding, keeping people unaware of which group they're in.
Correct. Ideally, the participants don't know if they got the real treatment or the placebo. Often, the researchers interacting with them don't know either, double blind. And sometimes even the people assessing the outcomes are kept in the dark, triple blind.
Why go to all that trouble?
To reduce bias from expectations. If you know you're getting the exciting new drug, you might feel better just because you expect to. If the doctor knows, they might treat you slightly differently. Blinding minimizes those psychological effects.
So a well-run, randomized, blinded trial, that gives pretty strong evidence.
It provides the strongest evidence we generally have that the intervention caused the difference in outcomes observed between the groups.
The source also mentions something called allocation concealment.
Ah, yes. That's like an extra layer of rigor for the randomization. It means the person enrolling the participant into the study doesn't know which group the next person will be assigned to.
So they can't consciously or unconsciously influence who gets into which group.
Precisely. It prevents manipulation of the randomization process.
Okay, but even this gold standard isn't foolproof, is it? There are limitations.
Oh, definitely. Sometimes, just by chance, randomization doesn't perfectly balance the groups, especially if the study is small. Blinding isn't always practical. I mean, you can't really blind someone to whether they had surgery or not, right? And RCTs can be expensive, complex, sometimes take a long time, and they're often done in quite controlled settings with specific patient groups, so the results might not perfectly apply to everyone in the real world.
And then there's that slightly funny example that really drives home the importance of context, even with an RCT. The parachute one.
Oh, the parachute trial. Yes, that's a brilliant, slightly satirical paper. Researchers supposedly randomized people jumping from an aircraft to either use a parachute or an empty backpack.
Okay.
And they reported finding no statistically significant difference in death or major injury between the two groups.
Which sounds completely insane, unless...
Unless you read the fine print, which revealed the aircraft was parked on the ground and the jump was about 2 feet.
Okay, that makes more sense.
It's a humorous way to make a very serious point. Even the most rigorous study design, like an RCT, produces results that are only meaningful within the specific context they were tested. You can't just blindly apply findings without thinking critically about the situation. Common sense still matters.
That's a fantastic illustration. So we have these different study designs, each giving us clues, some stronger than others, about health patterns, risks, and whether interventions work. How does all this scientific evidence actually get used to shape public health policy? The big stuff, laws, regulations, health programs.
Yeah, that translation from research to policy is, well, it's often not a straight line. It's complex. The evidence policymakers consider isn't just quantitative data from studies.
It includes other things, too.
Definitely. Qualitative information plays a role, things like personal stories, community feedback, expert consensus reports. Think of it like building a case in court. You use different kinds of evidence.
And the sources pointed out a disconnect, sometimes, between the worlds of science and policy.
Yeah, they use the phrase parallel universes. Scientists often prioritize methodological rigor, statistical significance, the hierarchy of study designs we've been talking about.
Whereas policymakers have different pressures.
Different timelines, for sure. They need clear, actionable information. They have to consider political feasibility, costs, public opinion, competing priorities. And unfortunately, data can sometimes be cherry-picked or misused to support a pre-existing agenda.
So just doing good research isn't enough. You need to get it into the right hands in the right way.
Absolutely crucial. The sources really stressed the role of advocacy, and they talked about policy entrepreneurs.
Policy entrepreneurs, who are they?
Basically, they're champions. Leaders who understand both the science and the political process, who can effectively package the evidence, build coalitions, and push for policy changes grounded in that evidence.
So bridging that gap between the lab bench or the epidemiology report and the halls of government.
Exactly. It's about communication, persuasion, and navigating the political landscape.
And, okay, let's say a policy does get passed based on evidence. Is that the end of the story?
Not at all. You absolutely need to evaluate whether the policy actually achieved what it was supposed to. Policy evaluation is critical. Did the new law change behavior? Did the health program actually improve outcomes?
How do you measure that?
There are frameworks for this. The source mentions one called our-aim. It provides a structure.
Our-aim, what does that stand for?
Let's see. Reach. Who did the policy actually affect? Effectiveness, did it work? What was the impact? Adoption, how widely was the policy or program taken up by institutions or settings? Implementation, how consistently was it delivered? What did it cost? And maintenance, did the effects or the policy itself stick around long term?
That's quite comprehensive. It covers a lot of angles.
It does. It helps give a fuller picture of a policy's real-world impact.
Can you give us that polio vaccine example again? That seemed like a clear case of evaluation showing success.
It really is a classic example. So the scientific evidence showed that the live oral polio vaccine, OPV, while incredibly effective, carried a very small risk of causing paralysis itself.
Vaccine-associated paralytic poliomyelitis, or VAPP.
Right. Based on accumulating evidence about this risk and the availability of the inactivated polio vaccine, IPV, which doesn't carry that risk, the U.S. changed its policy.
Phased out the live vaccine.
Exactly. They went from an all-OPV schedule before 1997 to a mixed schedule, and then by 2000 switched entirely to IPV for routine childhood vaccination.
And the evaluation, what did it show?
It showed a dramatic drop in VAPP cases. And since the full switch to IPV, those vaccine-caused cases have been eliminated in the U.S.
Wow. So clear evidence led to a policy change, and evaluating that change confirmed a major public health victory.
A perfect demonstration of the cycle. Evidence informs policy, policies is implemented, evaluation confirms the positive outcome.
That's really powerful. Okay, final piece of the puzzle then. How is modern technology changing the way we even gather and monitor health information in the first place?
Technology is causing a massive shift in public health surveillance. Surveillance is the ongoing, systematic collection, analysis, interpretation, and sharing of health data. It's how we keep track of what's going on.
Like tracking flu outbreaks or foodborne illnesses.
Exactly. And traditionally, a lot of that was based on, doctors filling out paper forms, labs sending reports, slow manual processes. Now we have tools like electronic health records, EHRs, artificial intelligence analyzing data patterns, big data platforms handling huge data sets, even things like blockchain for secure data sharing.
So it's faster, more automated.
Much faster, often more accurate, and definitely more timely. Instead of waiting weeks for reports, you can potentially see trends emerging in near real time.
What are the big benefits of that?
You get quicker insights. results. AI might spot an unusual cluster of symptoms before humans even notice. This leads to enhanced disease prediction, potentially heading off outbreaks sooner, and allows for much faster, more coordinated public health responses.
The source also mentioned mHealth, mobile health apps.
Right. Think about apps on your phone. They can be used for surveillance, too.
How? People reporting symptoms directly.
That's one way. People could voluntarily share symptom data, location data during an outbreak, maybe track vaccination status. It empowers individuals to participate, potentially.
And creates another stream of data for public health.
A potentially very rich, very timely stream. These apps can also push information out alerts, health advice directly to people, improving awareness.
So it's a two-way street, potentially.
It can be. But, and this is a huge but, all this powerful technology and the massive amounts of data it generates come with significant ethical strings attached.
Privacy concerns. Security.
Absolutely. Top of the list. We're talking about highly sensitive personal health information. How is it collected? Who gets access? How is it anonymized, if at all? How do we prevent breaches or misuse? These are critical questions that need robust answers and strong safeguards.
So the potential is enormous, but the responsibility is too.
Precisely. We need to harness the power while meticulously protecting privacy and ensuring ethical use.
Wow. Okay, what a journey through this deep dive. We've really covered a lot. We started with epidemiology, that foundational detective work.
And then unpack the different study types. Cross-sectional for that snapshot prevalence view. Great for generating ideas.
But not causation. Then case control looking back, cohort looking forward, better for associations over time.
Right. And then the RCTs, the randomized trials, are best tool generally for nailing down cause and effect for interventions, despite their own limitations and that parachute caveat.
Yes. And we saw how all this evidence feeds into the complex world of policy, the parallel universes problem.
The need for advocacy for those policy entrepreneurs, and the vital importance of actually evaluating policies using frameworks like RAIM, like with the polio vaccine shift.
And finally, this tech revolution in surveillance. EHRs, AI, mHealth, transforming how we track health in real time.
They're bringing those really crucial ethical challenges around data privacy and security right along with it.
It really underscores how important it is for all of us, just navigating daily life, to have some understanding of these concepts. What does this study actually mean? How strong is that evidence?
Exactly. Not all headlines are based on the same quality of evidence. Knowing the difference between a correlation from a snapshot study and causation suggested by an RCT is huge.
So as we wrap up, maybe here's something for you, the listener, to think about. Given everything we've discussed, the different strengths and weaknesses of studies, the hurdles in getting evidence into policy, the power and pitfalls of new tech, how do we make sure that the best available scientific evidence truly guides our public health decisions, especially in a world just flooded with information and, let's face it, competing interests? How do we ensure science leads the way?